It's now time for the CEO report, and I'd like to invite Dr. Bill Thorworth to the podium. So, Bill?
Thank you very much, Tim. Let me make sure. Good. It's my pleasure to give my fifth report to Council. And as it says here, I have no financial disclosure, but really have to disclose my 31-year support for and respect for the ACR Council since I began attending all the way back in 1987. I want to cover several things today. First, I want to introduce our new JACR Editor-in-Chief. Secondly, review some of the many highlights, and I really say a few of the many highlights that have occurred since we met last year. I wanted to emphasize the ACR's efforts to support and empower members, council, and chapter leaders, and we'll talk particularly about the revision of the meeting, and then promote to all members that of the council and chapter leaders that we really have to become the champions for the implementation of the PAMA mandate for appropriate use criteria consultation. So first, and I guess I should have a drum roll here, our new editor-in-chief. The JACR is very pleased after a complete search to announce that Dr. Ruth Carlos will be our new editor-in-chief of JACR. Ruth? And we look forward to this next era. So again, just to cover a few highlights for the council, I wanted to say the new Commission on Publications and Lifelong Learning. This is a restructuring of the former Commission on Education. It's going to guide the unique learning environments of the college, things like AIRP and our Education Center. It'll be a direct link to the JACR and to the ACR Board of Chancellors, and it'll integrate across all the ACR staff use of our educational platform, what was called Radiology Curriculum Management System, now Cortex. The publications team is really a tremendous team, and wanted to highlight a recently received award. This is from March for an issue from this year in May, for an issue last year in May, for the special issue on artificial intelligence and machine learning in the ACR Bulletin. The American Society of Business Publication Editors recognized this with a National Gold Award. Our Commission on Patient and Family-Centered Care has assumed responsibility for the Population Health Management Committee in order to coordinate efforts across the college. There are many efforts already going on in things like breast cancer screening, lung cancer screening, colon cancer screening. But again, this really shows, I think, again, the dedication and the change, as Jim pointed out, in our strategic plan to population health management. Also, we're going to incorporate lay person input into guiding those programs, a critical element of being patient-centered. In addition, the Patient and Family-Centered Care Commission has launched this toolkit that you, counselors and others with whom you work, you can use this as really a toolkit to improve your practice and enhance the patient and family-centered care activities in your practice. Quality, as we know, has long since been, quality is our image, is sort of a byline for the college. We have the new and improved the accreditation program in order to make web-based submissions easy for our members and the practices and the facilities you serve. The FDA recently approved the tomosynthesis accreditation program, again as a supplement to the long-standing mammography accreditation. And the National Radiology Data Registry. Participation has been growing rapidly, now with over 4,000 or almost 4,000 radiologists using this for MIPS reporting, the Merit-Based Incentive Payment System reporting to CMS. It also provides a great research opportunity, I think, from the registry databases. I wanted to highlight also, as far as quality, the quality and safety meeting that's going to be done in collaboration with the data science meeting that's going to be held in October 26th through 28th in Boston, and I really strongly encourage all of you to consider this to attend. Our research center at 1818 Market Street in Philadelphia has a long and storied history as far as its contributions in both radiation oncology and radiology. This year, at the beginning of the year, we had to have submissions for the renewals of the grants for ECOG Akron and for Energy. The RTOG Foundation is part of Energy. That particular grant was over 1,000 pages. The tomosynthesis mammography trial has been launched. It's going to include 160,000 women, and how tomosynthesis can improve potentially and document that as far as breast cancer detection. And the IDEAS trial, imaging dementia with evidence for amyloid scanning, has just been completed, and we look forward to the results of that. That was an example somewhat similar to the NOPR in the past of coverage for evidence determination for Medicare payment. The ACR Foundation, as I announced to you, all of you last year, has been refocused on a direction of health policy research, very much separate from but complementary to, I think, other foundations in radiology. We had matching challenges from the Advanced Radiology Services Foundation in Michigan, as well as our ACR Board of Chancellors, and we're able to, this year, raise over $320,000. So I want to say a thank you to all of you who participated, either on a practice level or individual level, to support the foundation. This really is investing in our future. The board has done other things, though, in addition, including a strategic investment of recent operating margins in new and improved association management system that we'll be putting into our system over the next 12 to 18 months. There's an acceleration of the ACR credit process, so again, to ease the submission of accreditation applications and to make sure that all of them are dealt with equally. The ACR Innovation Fund, this was launched 2 years ago, and we've now had 4 cycles of grant applications with many projects approved and some now actually being completed. So it really has been a tremendously wise investment on the part of your board. Again, getting back to empowering our members, the development of meaningful and quality metrics. We know that we're all now, radiologists are accountable for the care they provide, but let's measure things that really count. The registry reporting through our qualified clinical data registry, as I mentioned earlier, is now reporting for almost 4,000 radiologists, and I expect that to exponentially increase as we get closer to the real requirements of the MACRA legislation. Increasing member engagement, in other words, not just participation, but actual engagement with the college. The redesign of the ACR.org website that's been launched, and I hope all of you have visited there frequently. We had over 3.2 million visitors in 2017. The search function there will help you navigate the website. I think it is making a great improvement. The incredible growth in the ACR Engage platform and the communication and community that it's created, communities, I should say, that it's created have really been fantastic. Rise in social media presence of the ACR, and a striking fact to me was that 93% of medical imaging news articles when searched have some quote or citation of the ACR, and it really does show how we are front and center as far as the outside world. This is just a website, this is just a screenshot from the ACR.org website, and again, I encourage all of you to go and make full use of it. Now, as far as empowering the council, this was, again, a recognition of the need to refocus the annual meeting, as has already been described, on the governance and the council activities and not schedule conflicting program, even though high-quality educational program that drew away from the council. The board leadership is referring any policy-level question that comes to them to the council, knowing that the council is, in fact, the policy-making and determining body of our organization. Empowering our chapters. The monthly chapter leader updates that are issued from the organization and from staff. The signing of the affiliation agreements. 30 of our chapters have already signed at this meeting yesterday the affiliation agreement, and we have anticipate everyone else signing on there as well. We have dedicated staff specifically for chapter activities, and the Radiology Advocacy Network and other networks that help link and promote communication between the chapters. Expanding state advocacy. Jim cited the issues that we had with Anthem. There's no question that with those types of payer incidents and with Medicaid being a higher profile, that we're going to need more and more state-level advocacy. The ACR acted as the coordinator for a multi-society letter, as was displayed. And you'll hear much more about this during the Advocacy and Economics session, and then, of course, the Government Relation Hill visit preparation on Tuesday afternoon. So now let me shift to the promotion, and this is where I'm really asking all of you to go out and be champions in your communities about the promotion of appropriate use criteria. The future really is now. It is time for action because January 1st, 2020, as currently scheduled, CMS is going to require that referring providers document that they have consulted appropriate use criteria for advanced diagnostic imaging services, the modalities you see listed there. The ACR was the driver of this because after 13 successive cuts in reimbursement from 2005 Deficit Reduction Act forward, we were ready to say we're going to be part of the solution, promoting appropriate use of our services. The radiology has experienced no broad CMS cuts since the introduction of this PAMA legislation segment. So what are the key goals? What we're trying to do is really continue to promote the move from volume-based care to value-based care. We know we're going to be accountable for that. We've got evidence-based point-of-care consultation rather than the laborious prior authorization processes used by many payers. It really moves us, as I said, toward value-based care and protects patients from unnecessary procedures and those that involve radiation. It also promotes care coordination between ourselves and our referring colleagues. The ordering physician, and this is key because it is different than prior authorization, the ordering professional has to consult these AUC. The radiologist cannot do it for them. And via a qualified clinical decision support mechanism that can be integrated into the electronic health record or through a no-cost web-based portal. And the ACR anticipates that a unique identifier for every one of these consultations will be part of the claim process and part of the referral request that you get. CMS has been moving steadily with feedback from multiple stakeholders in order to move toward this implementation that we anticipate in 2020. But between July of 2018 and December of 2019, actually, referring providers can actually get credit in the merit-based incentive payment system for using these appropriate use criteria. And you can promote that to your referring colleagues. In January of 2020, there will be a full implementation, but with a one-year educational operations testing period. And again, this will be more covered more fully in the economics forum coming up. So the CMS has allowed 6 years for the referring physicians and the insurers to get ready for this, as well as the electronic health records. Meanwhile, the appropriate use criteria decision support mechanisms have successfully entered the private market with over 500 health systems and 2,000 acute care facilities now using this in all 50 states. As I said, it's available through that free web portal as well. So here's a heat map of Care Select imaging, with one of the primary entries being the content from ACR Select, and the number of electronic health records with which it's already integrated. Here are some of the selection of the appropriate use criteria contributors, including ACR Select, but also those from the American College of Cardiology, the Society of Nuclear Medicine and Molecular Imaging, National Cancer Comprehensive Network, and Choosing Wisely from the American Board of Internal Medicine Foundation. This is built into the quality payment program with CMS, and in their final rule last year, again, they indicated that the ordering physician can get high-level MIPS credit for that activity. This is not prior authorization, and please, as you go out and champion this in your communities, stress this fact because, as you'll see in a few slides, the prior authorization is viewed with a very dim light by our referrers. This is done point of care. There are no delays. There's no FTEs sitting in the referring physician's offices on the phones waiting for Mother May I approval. There's no hard stop, and it's an educational tool for those consulting physicians. So this survey, which was just released by the American Medical Association in mid-March, showed that 84% say that prior authorization is high or extremely high as a burden to their practices. The American Academy of Family Physicians had come out with a policy statement that encourages electronic approval rather than the prior authorizations before. This has been demonstrated to be successful as far as controlling inappropriate imaging. And again, these are just a couple of examples, and I encourage you to go to the ACR website as well as the RScan website where this Care Select imaging is being used in the RScan project with the Choosing Wisely criteria. I would be remiss if I didn't take one moment to thank a good friend and icon in radiology, and that's Dr. Bill Bradley, who we unfortunately lost last fall. But I would ask for a moment of silence, but Bill was never silent, so I'm not going to do that here. I do also want to highlight, though, our fantastic ACR staff. following the numerous hurricanes last year, in a relief fund effort, we were able to raise over $27,000 to contribute to multiple agencies that were supporting the recovery from that. There really is a fantastic group that I get to work with every day. In fact, we've also added on a program we called ACR Cares and intended to do volunteer work based on a trial we did over the holidays last year where we substituted for our holiday party to have our staff go out and do volunteer work in the communities surrounding Reston and Philadelphia. So again, it's really a tremendous group that I get to work with, and I'm very proud to stand up here on their behalf. So you're... So I hope I've impressed upon all of you the talented, dedicated staff is working for you every day to empower you as per our core purpose statement. Thank you very much.